Part 6 of the 12-lead ECG review. We're going to talk about ECG changes related to chamber size, atrial and ventricular chambers, and some additional ECGs that are not necessarily cardiac in nature, but are other systemic issues that could cause ECG changes. So we're going to identify left and right atrial enlargement on the ECG. We're going to identify right and left ventricular hypertrophy, identify pericarditis, which is a STEMI mimic on the ECG, identify pulmonary embolism, and then describe ECG changes associated with hypothermia, hypo and hyperkalemia, and hypercalcemia. So, the 12-lead ECG can indicate heart chamber size. So remember, voltage or electricity is going to go to bigger chambers or more muscle. So when those muscles become enlarged within the heart itself, you're going to see that show up as enlarged waveforms on the ECG. So if you see a wide R wave, the ventricle may be enlarged. An abnormally high R wave, you may have ventricular hypertrophy, or an abnormally deep S wave, ventricular hypertrophy, or you could also see large P waves as well. So for right atrial enlargement, results from chronic pulmonary disorders. Remember, a lot of your right-sided heart issues do come from pulmonary disorders, but it is a precursor to right ventricular hypertrophy. Usually you'll see a higher than 2.5 millimeter P wave in lead 2 and a high P wave 1.5 millimeters or greater in V1. So with right atrial enlargement, you'll see that we have the large P waves right in leads 2, leads 3, and AVF here. We also have a P wave that is biphasic in V1. With left atrial enlargement, we're going to have a longer P wave, greater than 110 milliseconds or 0.10 seconds. Peak to peak of the P wave is longer than 40 milliseconds, and you've got a predominantly negative P wave in V1. And this can be caused by hypertension, things that increase afterload. So in this case, we're going to see a predominantly negative P wave in V1. We're going to see this notched long P wave in 2-3 AVF is where we're seeing it right here. With right ventricular hypertrophy, this is caused by pulmonary hypertension. So typically, again, you got your right-sided heart issues caused by some type of pulmonary issue. So in this case, pulmonary artery, the pressure has increased, which leads to the right side working even harder. So I see the QRS-T discordance in V1. So remember, that's going to be an upright QRS or an R wave that's upright and a inverted T wave. R wave in lead AVR, the amplitude's taller than 5 millimeters. We don't have an AVR here, but we've also got a very large upright R wave in V1. For left ventricular hypertrophy, you got a deep S wave in V1, V2. Your tallest R waves are going to be in V5 and V6. And you're also going to see the QRS-T discordance. Typically, left ventricular hypertrophy is going to be caused by hypertension or cardiac abnormalities. Other cardiovascular conditions, the pulmonary embolism, acute intracranial hemorrhage, electrolyte abnormalities. So, benign early repolarization. So this is something that's usually benign and it's not going to be an issue. In this case, you may see a fishhook or a J appearance in the wave. At the J point, a concave ST segment morphology as well. This is, if you look here in V2, you'll see the concave or the sloped morphology there. Pericarditis. So a STEMI mimic, one of the big things about pericarditis is you need to get a history. Did they have a history of shortness of breath, recent infection or fever? Do they have positional chest pain? So it may feel different than just your cardiac chest pain that's associated with angina. You've got diffuse ST segment elevation. concave and depressed PR segment, except in AVR, and reciprocal ST depression is never seen. So you may see the ST elevation in contiguous leads, but you're also going to see them across the board. So if you notice in your V leads here, you've got ST elevation across the board, but you've also got that concave ST segment there as well. So history is going to play a huge part in diagnosing this. Pulmonary embolism has a unique pattern. It's called the S1Q3T3 pattern. So S1, you're going to see a deep S wave in lead 1. Q3, you're going to see a deep narrow Q wave in lead 3. And T3, a T wave inversion in lead 3. So we'll look here. So in S1, you see this real deep, ugly S wave. And then in lead 3, you've got a Q wave right here, and you've got T wave inversion right here. So obviously, there's going to be other things that you're going to use to diagnose pulmonary embolism, but this is something that you may see. So severe hypothermia, an Osborne wave may show up. Now remember, when you're seeing an ECG with somebody in hypothermia, you're probably going to see a lot of artifact from shivering as well. Hyperkalemia, you're going to see Hyperkalemia, you're going to see a tall peaked asymmetric T wave, possibly a flattened P wave. And remember, as hyperkalemia continues, this wave is going to flatten out and it's going to merge in with your QRS, and it may eventually become a sine wave when you've got very high potassium levels. With hypokalemia, you're going to have the opposite. You're going to have a lower flattened T wave, and then sometimes you'll see the development of a U wave. Hypercalcemia, you're going to see a shortened QT interval. So my Q and my T is very short, and that's because you're going to have a very quick depolarization, where on the flip side, with hypocalcemia, you're going to see a lengthened QT interval. So the problem with the lengthened QT interval, like we see here, so we have a real long QT interval here. The problem with that is that it prolongs the vulnerable period. So this ends the review for part 6.